Thank you for joining us for this webinar organized by the American Society of Echocardiography. This webinar will focus on how we should be prepared as echocardiographers to protect ourselves and our patients with best practices, specifically as it pertains to perioperative and periprocedural transesophageal echocardiography. We have assembled an outstanding panel. My name is Alina Nicora. I'm a cardiac anesthesiologist at Duke University Medical Center. We also have joining us Dr. Jasdet Maldonado. She's a cardiac anesthesiologist at Cleveland Clinic Foundation. Dr. Smadar Court, she's professor of medicine and director of non-invasive imaging at Stony Brook in New York. Dr. Sylvia Munoz-Price, she's an enterprise epidemiologist and professor of medicine at Froedtert Hospital and the Medical College of Wisconsin. Dr. Piers Barker, he's professor of pediatrics and pediatric cardiologist, director of non-invasive pediatric imaging at Duke University. Dr. Burkhard Mackensen, he's professor of anesthesiology at University of Washington in Seattle, director of interventional echocardiography. And last but not least, Dr. Madhav Swaminathan, he's cardiac anesthesiologist at Duke University and a president of the American Society of Echocardiography. Next slide, please. I would also like to thank our sponsor, Edwards. And also, I would like to thank Christina Lafuria and Liz Lane for making this webinar possible. Please ask questions. You can submit all your questions using the Q&A icon at the bottom. There is also a thumbs up icon which will allow you to upvote a question that has already been asked by another attendee. Next slide, please. As an agenda of the webinar, we are going to start by presenting the document that has been prepared by the Council on Perioperative Echocardiography as a supplement to the American Society of Echocardiography COVID statement. And this document specifically refers to specific consideration regarding perioperative and periprocedural TEE. We would also like to thank the Society of Cardiovascular Anesthesiologists for endorsing this document. And this is going to be presented by Dr. Jasdet Maldonado. Dr. Sylvia Munoz-Price will continue talking about personal protective equipment and environmental disinfection. Direct from the front line, Dr. Court will present on the New York experience at her center, and Dr. Mackensen will present on the experience at the University of Washington in Seattle. And Dr. Barker will talk about specifics related to perioperative echocardiography in pediatric, but also in adult congenital heart disease patients. And at the end, we will have question and answer. We will allot time for question and answer with the panel. If there will be questions which remain unanswered, we will categorize them. We will have panelists answer them, and then we will put together all the answers in an email which will be sent out to all the attendees. Next slide, please. So without any other further ado, I would like to invite my colleague Jasdet Maldonado to present the document.
Thank you, Dr. Nicora, for inviting me to present at this panel. It's my honor to present the COPE statement of protection of patients and providers from performing perioperative periprocedural TE during the coronavirus outbreak. Next slide, please. So why are we here? So we're here because TE is classified as an aerosol generating procedure. What that means is that it can provoke the aerosolization of a large viral load, hence it presents a risk. If we have a secure airway, an intubated patient, that does decrease the risk of viral transmission. However, the risk definitely does remain with direct contact with secretions and may actually be higher with direct contact with secretions. The areas during the procedure during which there's the greatest risk includes when there's the intubation of the TE probe, if during manipulation of the probe the patient coughs due to suboptimal paralysis, and then also while manipulating the probe. Next slide, please. So our objectives today are pretty simple. We're going to discuss whom to image, where to image, and how to image. Next slide, please. Regarding whom to image, we reference here the ASE statement on protection during COVID-19, in which the recommendation is that if the examination is unlikely to provide clinical benefit, it's best to postpone or cancel it in the interest of safety. So another option would be to use an alternative imaging modality, such as TTE. Next slide, please. So with the whom to image, there are certain clinical scenarios and surgical procedures in which the benefits do outweigh the risk. For the clinical scenarios, the most common would be an urgent or emergent cardiac surgery. Other possible scenarios would include emergent non-cardiac surgery in patients with cardiac comorbidities, and potentially a patient who is hemodynamically unstable due to secondary undifferentiated shock. So what this means is a patient who's in shock, you're looking at the clinical scenario, you're looking at your hemodynamic parameters, looking at other factors, and you can't make the diagnosis, and then TE would be the most appropriate tool to help in making the diagnosis. Surgical procedures in which, again, TE the benefits would definitely outweigh the risk would be infective endocarditis with valvular and perivalvular involvement, a Stanford type A dissection with associated complications, initiation of mechanical circulatory support, both temporary and durable, an MI with mechanical complications such as VSD, LV wall rupture, and papillary muscle rupture, and then the assessment of prosthetic valves. Next slide, please. So again, we want to emphasize, look for alternatives. Possible examples could include, old school direct visualization of the heart. That's something we do every day. We can take a look at our hemodynamic data, which we likely already have available. Again, TTE, good alternative. Another ultrasound modality as an alternative would be epicardial ultrasound. And I just want to highlight that there is an AAC position paper that you can reference regarding performing a comprehensive epicardial echo exam. And then finally, if you're in a hybrid room, potentially fluoroscopy. Next slide, please. So this is an algorithm for determining need for intraop TE. So we start with an emergent cardiac surgery case is posted. It's a known COVID patient, or it could be a patient under investigation. Next, please. So what you ask yourself first is, TE indicated, is it really essential? If your answer is no, next please, you may want to consider TTE before the start of the procedure. Why? If you perform a TTE, you could get some valuable information regarding RV and LV function and also valvular function. If your answer to this question is yes, and why would it be yes? Going back to those clinical scenarios, to those type of procedures, if your answer is yes, then you go ahead and you perform your TEE and you're going to don airborne precautions. And then finally, you might be in a scenario where you decided against putting a TEE because the risk outweighed the benefits. However, you come into hemodynamic instability, or unfortunately there's a procedural complication. At this point, you may want to place a TEE probe, but again, to please don airborne precautions. Next slide, please. Regarding where to image, you want it to be a dedicated space. And we do recognize there are hotspots around the country in which every space is a COVID space. But those places in which we're still practicing in parallel care for COVID patients, non-COVID patients, you wanted to dedicate an OR, a couple ORs. You want to dedicate a hybrid room and an ICU unit. Similar, you want to limit entry and exit. So whether this be by posting a sign, by including it with your checklist on donning and doffing, or actually mechanically closing certain entries and exits to redirect workflow. Next slide, please. Regarding how to image, you want to take a direct look at the pathology of the patient. So you want to make the exam as focused as possible, but yet still comprehensive. For instance, if you're looking at your aortic valve, you don't want to miss a dissection. But what you want to do is limit your exposure time. Regarding the personnel should don airborne precautions. And I know if there aren't already questions related to why the airborne precautions, please rest assured that in the next presentation, that's going to be further discussed. The terminologies of aerosol generating procedures, airborne precautions, droplet precautions, airborne transmission, droplet transmission, all that's going to be further clarified in the next talk. Regarding the exam and the probe insertion and removal, our recommendations for it to be performed by the most experienced personnel. That being said, if there's more than one team member, because there's enough PPE, you may want to consider one person doing the exam, another person handling the equipment and the knobs. That would decrease the transmission of secretions from the probe to equipment and from there to other vectors. But you have to see if you have enough PPE in order to do that. Regarding the equipment, you want to follow your institutional protocols. You definitely want to remove any accessories from your echo machine. Again, decrease the amount of vectors for transmission, and you want to use plastic covers. Here on the left-hand side in the top, we have an image thanks to Dr. Mackinson from University of Washington on how they are putting a plastic cover over their entire machine. On the bottom, you can see an example of how to cover the probe. This comes out of a recent article in JCVA. And it's basically taking your regular ultrasound probe cover, cutting a slit at the end, putting a white block so that the probe cover doesn't go into the patient, and then extending the probe cover over the TEE probe. At my institution, for instance, we're using C-arm drapes to drape our ultrasound machine. So basically, be creative and work amongst your resources. Next slide, please. Now, this is a checklist on how to take care of yourself, protect the equipment, protect the patients. And I just want to highlight a couple things here. So before the procedure, again, don PPE for airborne precautions. Use plastic barriers both for the probe and for the machine. During the procedure, perform a focus exam. Avoid unnecessary contamination. So really watch your hands. If you're touching the probe, don't go back and touch the anesthesia machine or touch the electronic health record. Really watch your hands and what you're doing with them. And then after the procedure, the way to disinfect the probe itself is standard procedure. The probes are already disinfected for viruses, and that includes the coronavirus. However, I do want to highlight that for equipment in the probe container to wipe it down 2 times. Next slide, please. Now, is there a role for learners? If learners are involved in performing exam, there are definitely risks involved. It does naturally prolong the exam time, so there's an enhanced risk for contamination and exposure to the learner. In addition, there's more use of PPE within the team. That being said, doesn't mean that learners can't learn during this time. All trainees, from medical students up to fellows, can interpret and report. And we do state that fellows, especially now that they're further into their training, can perform TEE if they're trained into their institution's COVID protocols. Next slide, please. Finally, key takeaways include that TE does increase the risk of transmission of coronavirus. This risk is higher in non-intubated versus intubated patients. Please consider alternative imaging modalities and then do proceed with TEE if and only if the benefits heavily outweigh the risk. Thank you.
All right. Well, thank you very much for inviting me to participate in this event. And I'm going to talk to you about personal protective equipment and environmental disinfection during these procedures. So next slide. In infection control, we know, especially at SAF-VOR, that infectious organisms go from a patient who has the organism, either infected or colonized, to a patient or person, including healthcare providers, that is negative. So next slide. So we have different pathways for transmission depending on the type of organism we're talking about. It is different from MRSA, for example, is different than pertussis, is different than TB, etc. In COVID, for SARS-CoV-2, We know that the primary ways of transmission are two. One is contact, and the other one is droplet. So the equipment and the environment might be contaminated, and we'll address them shortly. The provider with both the hands and the clothing need to be addressed, and also contamination through respiratory droplets and airborne transmission. So next slide. Before I get into the details of what you need to wear, let's talk a little bit about the difference between droplet transmission and airborne transmission. Let's start with droplet. So droplet transmission happens with respiratory droplets that are big. These are 5, 10 or more microns in diameter. And because they're big, they're heavy. And because they're heavy, they fall. So when you're talking on where you're coughing, they're going to go into the air, and shortly thereafter, they're going to fall into the ground. So because they're big, what protects us is a standard face mask. We do not need a respirator to get protection from droplet transmission type of organisms. Examples of organisms that are associated with the droplet transmission include influenza, pertussis, mumps, and COVID in most cases. Let's talk now about airborne transmission. Airborne transmission happens when the organisms, the infectious organisms, are contained within smaller particles. They're called droplet nuclei, and they are less than 5 microns. And the importance of knowing that is they're not heavy enough that they're going to fall immediately into the ground, but rather they're going to stay suspended in the air for longer times. It's not going to be forever, but it's going to be longer than respiratory droplets. So because they're smaller, we need a different type of mask to be protected from this type of organism that is transmitted through airborne transmission. So we require respirators that filter the air. So that includes N95, or you can also wear PAPRs or other type of respirators. And I'll get into a couple of examples in the next slide. Examples of infectious diseases that are transmitted through airborne transmission include disseminated shingles, tuberculosis, and measles. Next slide. So ASC has guided its members that TEE is an AGP, which is accurate. So for an AGP, an aerosol generating procedure, whatever organism that you have in the respiratory tract is going to be aerosolized. So you need to protect yourself for an airborne transmission. When you have an airborne transmission that in addition to that is contact transmitted, you are going to need to wear 3 layers of protection. So number 1, contact precautions, that includes gowns and gloves, plus airborne precautions. Airborne precautions basically means you need to wear a fitted N95 or a PAPR or a capper or other respirators, and I'm going to give you an example in a second, plus eye protection. And that can be goggles or face shield. Remember that your regular eyeglasses are not considered enough eye protection. You need to put goggles or a face shield on top of your eyeglasses. So if your facility has limited supplies of N95s, then you're probably doing conservation interventions. So what you can do is, if you're wearing an N95, just put a standard face mask, so a surgical face mask on top of your N95. Do the procedure. And then at the end of that case, you remove the standard face mask and you get rid of it, but you keep your N95 for the next case. And you can reuse the N95s until they do not mold well to your face. The other option is elastomeric masks. So elastomeric masks are used in construction. Painters use it fairly frequently. You also need to be fit tested for these masks, and occupational health need to make sure that you don't have lung or heart problems that will make you unfit to wear these masks. Something else to consider with these masks is that they have two types of valves. They have inhalation valves and they have an exhalation valve. The problem with these masks is that the exhalation valve does not have a filter. So your breath is going to contaminate the area surrounding you, which might not be suitable in the operating room. So just keep that in mind. And if you consider this mask for the operating room, you probably need to have a conversation with your infection control department. Next. All right. There are many kind of nuances in infection control and in procedures and in hospitals. So let's just say that for some reason, the procedure that you're doing is not considered an AGP. You do not necessarily need to wear an N95. You could wear a standard face mask. However, respirators are always preferable if they are available in your institution. Next slide. All right, so something that we mentioned is that because this organism is transmitted through contact, the environment and the equipment are very important. They should be disinfected in between usage. So after practicing more than 15 years infection control, I can tell you that the number one issue with cleaning and disinfection of the environment and the equipment is actually doing it. Whatever you put in the policy doesn't necessarily happen. So as long as you are actually doing the disinfection of either equipment or environment, that's a big plus. Any hospital-approved disinfectant is going to be effective against SARS-CoV-2. It is not a hardy organism to kill. Alcohol, bleach, hydrogen peroxide, quaternary ammoniums, all the hospital-approved disinfectants will destroy it. And as was mentioned in the previous talk, you should consider other solutions like covering the equipment with single-use plastic covers. And regarding the probes, always keep in mind that you need to use a manufacturer-approved disinfectant. Alcohol tends to be very frequently approved for probes, and the alcohol is going to be very effective killing SARS-CoV-2. Next slide. I was asked to go over these concepts just because the air is such a hot topic. So air changes per hour. In a regular hospital room, the air exchanges are going to be 6 per hour. That basically means that in an hour, that air contained within a room is going to be exchanged and filtered in between 6 times. In the operating room, the minimum number of air exchanges per hour is 15. And when the air is recirculated, it goes through a filter, a HEPA filter, so to make sure that the air that goes in is not contaminated. Also, in operating rooms, hospitals are required to pump air from the outside air into the operating room. Of course, it's filtered. It doesn't have organisms, but that happens at least 3 times in an hour. All right, next slide. The other concept that tends to confuse people is air pressure, the air pressure differential. So just like when you do a procedure, you go from clean areas to dirty areas. The air pressure differential in the hospital is the same. You should go from clean areas to less clean areas. And it doesn't mean that the air is going through the ventilation ducts from a clean area to a dirty area. That's not what it means. It means basically that if you have a room that is next to another room and you were to make a hole in between, an imaginary hole, the pressure will be in such a way different from one room to the other one, so that the air will flow from the clean area to the dirty area. That's what it means. So, for example, in the operating room is considered a clean area. You can argue that's not the case, but it is considered for engineering purposes a clean area. And thus, the hallway is considered a less clean area. So if you have a door in between and the door is open, then the air is going to flow from the operating room to the hallway. So what do you do in those cases? You close the door. That's the solution. It's not changing the pressure differential, it's keeping the door closed. Next slide. And you can go to the CDC and look at the recommendations for air exchanges and recirculation in the operating rooms, but here you have the data on how should the air exchanges and air recirculation be in operating rooms. The air movement relationship to adjacent areas should be out. So again, it flows from the clean area to the dirty area. The minimum total air exchanges per hour is 15. In my hospital, for example, we have 20 per hour. And recirculated by means of room units, meaning is the air in operating room A going to the air in operating room B? No, that's not acceptable. That's not, hospitals cannot do that. The air is only recirculated within the same room. It's not mixed all over the place. Next slide. And here you have examples of patient rooms and airborne isolation rooms. I'm not going to go into those details. If you have any questions, I will get into that. I'm going to stop there, and I'm sure you will have questions regarding PPE afterwards, so I'll wait for them. Thank you.
So I will share with you the experience at Stony Brook, and Stony Brook is located on the beautiful Long Island of New York, which is now a hotspot for COVID-19. Next slide, please. So in preparation for the surge, our hospitals had to take several steps. We almost doubled, actually more than doubled, the number of beds that we have in the hospital. And this is in addition to a field hospital that was created and still being built on our campus. Stony Brook is one of 4 sites that were designated as having a field hospital built there. We canceled pretty much early on all elective surgeries and procedures, and those are about 200 a day. That allowed us to protect staff from possible exposure to COVID-19, deploy staff who is now not being involved with those procedures, preserve scarce ventilators and PPE, and in addition, we were able to convert our ORs as well as the post-op recovery rooms into ICU rooms. Next slide, please. For structural interventions, what we've been doing is holding a weekly Zoom conference calls to discuss the patients that we have on the schedule that we did not get to perform the procedures. We also hold weekly phone calls with the patients. We make sure that our patients are as stable as possible. We discuss the results of those conference calls with the referring physicians, so we keep them on board as well. The goal is to postpone as long as possible those procedures as long as there is really no change in the symptoms and the patients are stable. Next slide, please. We had, over the last 50 days or so, we had several TAVRs. We use only transthoracic echoes for those. Those are performed by our sonographers who are wearing full PPE. And they enter the room only after the valve is deployed. So they're kind of waiting for the right moment, and then they step in, minimizing their exposure to the patient. The echo attending is reviewing the images remotely. If need to, we go into the room, but the goal is to try to review images remotely. Next slide, please. For mitral clip, we evaluate the patients very carefully. We had one inpatient that we could not safely discharge to home, so we had to perform that mitral clip. We had a very symptomatic outpatient that we brought in, and we have 2 additional patients that are currently on the schedule, and we closely monitor for progression of symptoms. Before performing any of these procedures, we evaluate for symptoms that could potentially be consistent with the COVID, and we make sure that we do not really do any procedure on a patient that could potentially have COVID. We don't have a point of care COVID test in our institution at this point. Next slide, please. We did perform 1 percutaneous aortic valvuloplasty in our institution. That was a very symptomatic inpatient, and there was just no way to discharge the patient to home. Otherwise, we did use transthoracic echo immediately post the procedure as well as the following day. So TE was not used for that procedure. Next slide, please. Over the last, again, it's about 50 days now, we performed less than 50 cardiac surgeries. These were urgent or emergent surgeries, mainly CABG and aortic dissection repair. For each one of these cases, we really assessed the risk-benefit and then made the decision whether or not it needs to be done. Really, for all of these patients, we elected to perform transthoracic echo prior to the surgery in order to assess the LV, the RV function, and exclude significant valvular heart disease. We minimized the number of operators just to experience cardiac anesthesiologists. And even though we are a teaching institution and we typically have both residents and fellows in the OR, we did not allow for any hands-on teaching. We do have simulators at Stony Brook, and obviously everyone has access to the images after they're obtained. Next slide, please. So we do treat, obviously, those TEs as airborne procedures, airborne generating procedure or aerosol generating procedures, and therefore utilize airborne precautions. So the anesthesiologist or cardiologist, whoever is involved with the case, is wearing a full PPE, same thing with the surgical staff, and the PPE include gown, double gloves, face shield. We use N95 with a surgical mask on top in order to preserve our N95s. And we really do it for all our patients. The penetrance of COVID-19 is really high on Long Island, so we just assume that all of our patients have the disease at this point. We do consider keeping the patient's face covered with a towel or a drape during the entirety of the exam in order to minimize the risk of droplet liberation. Next slide, please. The intubation, extubation, as was mentioned before, is really the highest risk of aerosol generation. So for that, we use PUPPER, and some institutions do have intubation boxes. We don't have those available, but that's something to consider if you do have that available. We also try to minimize the number of people that are in the OR during the intubation and extubation periods. Next slide, please. The scanning protocol is a focused, problem-oriented. Like I said, all these patients get the transthoracic echo before, so there are really no surprises. And we also try to minimize the manipulation of the probe, especially transitioning from mid-esophageal to transgastric positioning and vice versa. Next slide, please. For probe disinfection, we wipe it as we typically do with the enzyme sponge at the end of the use, but we also use a Seni wipe at the end and then insert it into a plastic storage container. We then wipe the machine as well as the probe container with a compatible Seni wipe, and we do that twice. Next slide, please. Patients that are immediately post-op in the CT ICU, if they are hemodynamically unstable, if there's any question, typically anesthesia is performing TEs on them. They know the patients, they're fresh out of the OR. But now during this COVID era, we again perform transthoracic echoes on these patients for initial assessment. And so far, there was really no need to proceed with a transesophageal echo after those transthoracics. Next slide, please. So final recommendation is really to have close collaboration between the echo lab and the perioperative staff. We do share scanning protocols, we share disinfection protocols. The echo lab just has more experience since we do perform more of those studies. And we also share evaluation of our patients. So we really try to perform transthoracic echo by the echo lab instead of intra-op TEs whenever possible. So next slide. And I would like to thank Jeremy Poppers, who is the chief of the Division of Cardiothoracic Anesthesiology, and the entire cardiac anesthesia team in our institution. And thank you, and I'll be available for questions later.
Hello, everyone. I'm following with the Seattle experience. Next slide, please. Well, as many of you know, we were the first in the country to be hit by the pandemic. So I'll talk a little bit about the past, the immediate past, the present, and the future. I'll also allude on the importance of testing for the COVID experience, and then talk about our structure, heart, and OR experience as well, the importance of universal testing, and how we protect us when we do a TE at UW Medicine. Next, please. So this all started in Seattle early on in January of 21st, when we actually had the first patient in the US diagnosed in Seattle. We then had some outbreaks in a nursing home in nearby Kirkland. And then the first death of COVID in February of this year, 29th of February. We then had a lot of attempts that were unsuccessful at first to isolate the spread. And by March 23rd, the governor of Washington State decided to institute a home order, which then led to a number of interventions, including rapid development that included a hospital protocol for all of the hospitals in the area, halting elective surgeries, and so forth. We then looked to the virology lab at UW to give us a hand in terms of helping with the testing capability, and it has been instrumental. Next slide, please. Now, talking about the immediate past and then also the present, if we think of it, we now, as of 2 days ago, had a community spread of about 12,000 patients or cases, better to say. And we had 682 deaths in the state of Washington. So in the end, even though initially we were a hotspot, we got lucky that we quickly instituted a lot of protocols and interventions to at least slow the disease and flatten the curve. As part of that, we used aggressive testing tools, including now more than 140,000 patients tested, positive of those 8.5%. We started immediately in March with a coordinating center for UW Medicine, and then cohorted patients to different units in the hospital, essentially restructuring our ICU and acute bed environment. We then currently looking also at a surge or kind of resurgical, staffing and increase of volume over time for our procedures and surgeries, as now this curve really has been flattening and we've come off our peaks. This map shows the distribution in Seattle and surrounding counties. So basically a map of Washington State with information. Next slide. Again, I wanted to point out and give a shout out to the UW Virology Division. They've been leading The cause in many ways, we now have even serology testing available. We have an antibody test that started several days ago. We do have PCR testing with both a longer time frame and a shorter rapid test, which I'll show in the next slides. Next, here's a dashboard which shows the timing from the beginning of March until currently, where you see the number of tests that were done at UW Medicine, peaking close to 3,000, now coming down quite nicely. So we're not at capacity for our testing, at least for our area. Next, please. Now, if we think about where we are in the continuum or the timeline of the disease and the pandemic, at least for Seattle, we are still in a contingency capacity, which is the middle yellow bar, if you will. So we have a goal to remain at this contingency care while maintaining all the protocols that have been implemented. This includes the adherence to social distancing outside in the city, as well as in the hospital, to avoid any resurge. Monitor outbreaks closely. We recently had another nursing home outbreak in nearby Tacoma. We also need to initiate now our plans for increasing, by gradual means, increasing our surgical and procedural volume. And that will lead to important discussions about universal precautions that include precautions for every patient, for every healthcare provider, and every day. Next, please. This slide just briefly shows a representation of a graph as it is assembled every day as a prediction graph for any state in the country, and also numerous countries across the globe. And this is done by the IHME here in Seattle, the Institute for Health and Metrics and Evaluation. And as you see here, this is the curve from April 24th or 21st, where our curve clearly has flattened, at least as deaths per day are concerned. Next slide, please. Now, when we think about our operative and cath lab and procedural volume, we certainly have seen a significant slowdown in volume overall. We have seen a huge reduction of our surgical volume, as well as our regular business in structural heart and in the cath lab. We have designated spaces for COVID positive, or at least patients that are under investigation. So we can rush an emergent case like an aortic dissection or a cardiac tamponade into an operating room that's reserved for that purpose, and it's also stocked or staffed differently as our regular operating rooms. We also have performed a number of structural heart disease cases, procedures such as TAVRs, valve-in-valve, and MitraClip procedures for those patients that either are prone to repeated hospitalizations or that have been in the hospital and couldn't leave the hospital without having a procedure completed. We are ongoing with our testing of every patient, meaning any patient that comes to the hospital for procedure or a surgery needs to have a test within 72 hours prior to the procedure, ideally a shorter period of time. And often these tests are now being repeated as well. We also have a rapid test that by technical aspects could be done within 45 minutes, but it's co-plated and therefore happens every 2 hours. And so the turnaround effectively is actually 2 to 3 hours, but certainly has helped in some of these emergent situations. For our protected TE, I have a slide coming up, and I would like to say that we now in multidisciplinary discussions across our UW Medicine environment to carefully consider how to increase procedural and surgical volume, which I think is not an easy task. Next, please. This slide just shows how we are currently using a procedural face mask in addition to a patient that is already being intubated to protect ourselves from the secretions of the patient. We also have a ultrasound sleeve over the TE probe, as you see here. That probe is passed through an opening that you can see on the left-hand side in that face mask. This face mask is usually reserved for utilization in GI scoping procedures, but lends itself well for this type of approach. Once the procedure is done and you want to remove the TE probe, you take the straps off the mask on either side and basically take the whole mask and the sleeve with the TE probe and the bite guard out of the patient, and then get rid of the material that you no longer need. That way you can actually stay away from any secretions at that point. Next slide, please. I would like to quickly thank Janelle Badulek at our institution, who is an emergency physician and critical care colleague, who has led our efforts on the ECMO side of things. I'm excited to say that today we have plans to consider, weaning one of our patients off ECMO. That's not an easy task. We've seen patients across the globe being on ECMO for extensive periods of time, up to 3 weeks. Janelle has been fantastic in that and has also helped me with a few of the slides. And then Drs. Baudel and Jelacic, who are behind a webpage and a research group that is named Gavia Labs. I recommend going onto their webpage. They have essential and very comprehensive information about the current COVID-19 outbreak. Thank you.
So first of all, my name is Piers Barker. I'm a pediatric cardiologist, and so I should start immediately by saying that it's a tremendous honor to be part of this webinar and to be and have the opportunity to speak with such a great group of people. My goal in the next 5 minutes is just to give a slightly different perspective in terms of perioperative echo and how we think about it for the pediatric or the adult patient with congenital heart disease. Next slide, please. So one of the things we do know is that COVID-19 seems to affect children very differently. And we know children are likely to be less either asymptomatic or minimally symptomatic. And when you couple that to either younger development or in the case of an adult congenital patient with developmental delays, you have a situation where they can be notoriously uncooperative with secretions, and because of their fewer symptoms, a situation where typical adult screening methods will fail, and that will create a situation of greater provider exposure without knowing about it. In addition, additional adult caregivers are usually present, which adds another person as an exposure risk. It's hard to find appropriate size face masks for children, or to find a toddler who's willing to wear a face mask. Young children may also have the potential for fecal transmission. They're not toilet trained. The developmental stages or delays may limit the cooperation, which can lengthen scan times, and the fact that the anatomy can end up being sometimes very, very complex can also mean longer scan time. So all of these things create an increased risk for provider exposure. One question that has come up quite a bit in the pediatric and congenital heart community is there any data on congenital heart disease putting patients at higher risk for COVID-19 complications? And even as recently as this afternoon in an American Academy of Pediatrics webinar, there is still really no data, just a handful of cases, nothing to draw conclusions from, although we are seeing some myocarditis present in children with COVID-19. Next slide, please. Thank you. So with, against this backdrop of potential increased and unknowing exposure, is the fact that perioperative echo will continue for these patients. Babies are going to continue to be born with congenital heart disease. Single ventricle patients will need to move on to their next stage of palliation. or cyanosis will become prohibitive. Adult congenital heart patients will also have indications where they will need to move urgently, or to shift gears and look at it in a slightly different way. Even as we move past the initial surge steps and get moving towards more elective surgeries again, there will be patients in whom we may not know the status as well as we would like. So that means that perioperative echo will be integral to the care of these patients, and that means that if we're in an uncertain area, then it's really important to maximize the anatomic complexity and the functional scan complexity to the provider's skill. The goal, again, as we've heard from other speakers, is to maximize the accuracy and detail, minimize the scan time, and minimize the direct involvement of additional personnel. It is fantastic for Dr. Nakora to invite me or one of my colleagues into the operating room when there's an adult congenital patient going on. But this is a situation where it's probably better to have the pediatric cardiologist out of the operating room. And so one way that can happen is by going back to the Who Wants to Be a Millionaire, the phone a friend, phone a pediatric or congenital cardiologist. So review the anatomy if it's a complex congenital patient, review the physiology, that what's expected for this stage of single ventricle palliation. What's the procedure? For instance, if it's a repaired transposition, the coronary arteries aren't going to come off in the normal position. So where will they come off? If it's a superior sinus venosus defect, what views are more likely to show the anatomy, and what, based on the type of procedural options, what is going to show the possible complications? Having the ability to have real-time or near real-time remote imaging and feedback also is really, really important. And as we've heard from other speakers as well, consider alternative imaging strategies to TE, and that can include what people have talked about. We can get really creative with agitated saline contrast because we can't use regular contrast, but lots of different options. Next slide, please. I would also like to explain that we would have a slightly different approach to point of care ultrasound as well for these patients. In the best of times, POCUS is a balance between speed, indication, and disease complexity. It certainly decreases provider exposure with equipment that's more easily scanned or cleaned and shorter scan time, but we do have to balance that in the congenital heart patient against less machine functionality and greater disease complexity, and having people be really comfortable with what they're going to see. Next slide, please. So as a result, at the moment in the pediatric congenital heart community, we're still recommending traditional transthoracic echo, just given the breadth of congenital heart disease. There's no point in doing a brief scan if someone then has to come in and get additional details. So better to do one scan. We also know that for children, especially, some techniques for assessing function and other parameters just don't work as well for children, and for a whole variety of reasons. However, I would absolutely defer to an institutional practice and provider skill if you've got a center that's really well established with this, and then certainly maximize the strengths of POCUS for immediate assessment of systolic function or fusion, but match it to the patient's underlying anatomy. A systemic left ventricle versus a systemic right ventricle, you're going to approach those differently. Obviously, if you're going to be doing point of care ultrasound, then really important to be able to archive that images, to review, to compare to prior studies, and to plan for future studies. And as an overarching principle, the rule has to be to do the study that answers the clinical question most accurately and completely in the shortest time, exposing the fewest people. Next slide, please. So that really brings us up to a quick acronym, and because I'm a pediatric cardiologist, we like kind of like cute acronyms. And for this one, this would be, in approaching perioperative echo in the time of COVID-19 is to think fast. Everything about this epidemic has been fast. The speed of cases, the speed of spread, how quickly we've all had to adapt our different practices. And so think the most focused study involving the fewest people, accurate and for the appropriate indications, safe with all the protective equipment we've been talking about, and speedy, and thorough and thoughtful. So really, again, thinking about each study, taking the time, maximizing the ability that we have to take care of these patients, and even beyond all of this, communicate and collaborate. You know, we are a group. It is so good to be part of this call and the American Society of Echo, because I think the whole approach has been working together. We need to talk, we need to collaborate. We really are in all of this. We really are all in this together. So thank you.
Thank you so much, Piers. That was great. I would like to thank all the panelists for the tremendous work they put into preparation of these slides. And it seems that the most popular question is regarding patients who are asymptomatic and not tested, and regarding patients who may have a negative test, given the prevalence of false negative tests. So what should we do with these patients? I know that you answered this question, Dr. Munoz-Price, but I would like you to actually say it out loud so that everybody can hear your answer.
You know, if you're going to do an AGP, just assume everybody's positive. And use the same precautions that we had discussed before, regardless of the results of the test. Contact precautions with gowns and gloves, plus airborne precautions with a respirator, plus eye protection with goggles or a face shield. I can elaborate on the reasons why. I mean, the number one issue is the test. Even though the test has a sensitivity that is supposedly around 90%, that is comparable to the gold standard. And we really do not know how good the gold standard is. It might not be that good. But at this point, that's all we have as gold standard. And as you just said in your many questions, there are questions about false negatives, patients that are behaving like COVID-19 positive patients but test negative, or initially test negative and then later on they're positive, or patients that are persistently positive. That is happening too, and might be because there's dead virus still present in the nasopharynx and oropharynx, and we are capturing that DNA. All these questions, all these uncertainties are resolved if you just do the same type of precautions for anybody that is undergoing an AGP, period. No exposures.
Great, thank you so much. I also have a question for Dr. Swaminathan. Is there any plan in the future at the level of the society to put together all this experience from the centers that have had a high number of COVID cases into some form of registry?
Yeah, thank you, Alina, and thank you to all the presenters. This was excellent. So at the level of the society, there are discussions underway of creating a registry. You know, ASE already has something called the Image Guide Registry, which is a registry for a lot of labs to send in images and reports. So these are including images as well. And so some of these are automated with preferred vendors. And so the mechanism already exists, and there are talks underway of collaborating with institutions that have rich sort of, you know, a lot of patients with COVID and lots of imaging and reports and experience that we can actually then collate into the registry using the Image Guide registry that we already have. But those plans are still underway and are being developed as we speak.
Great, thank you so much. And I have one last question for you, Dr. Munoz. You're in high demand. Speaking about long-term plans, when things will start opening up again and we will start doing elective procedure, should all the patients be screened for COVID? After we are on the tail of this pandemic.
So the question is, would you do something different with a positive versus negative test? And I think at this point, we're not, if the result is negative, it is the safest action for you is to assume that the patient is positive because of the false negatives and because of the incubation period. So I don't think that for you guys, for specialists that are doing TEEs, you should make much of a difference to know the results of the patients, because my recommendation will be just to assume that everybody's positive. That is the safest thing for you. We have seen many healthcare providers exposed with patients that were asymptomatic or were initially negative. And afterwards, we come to realize that that was a false negative, or the patient actually ended up being COVID positive. So just to bypass all this uncertainty, just continue doing all those precautions.
Great. Thank you so much. I think we will stop here, just to be mindful of everybody's time. I want to again thank you, all the panelists, and I want to thank all the attendees. We will pull together the questions, categorize them, answer them, and send them to you via email. Thank you so much. Have a good evening.